This presentation is Hypertensive Emergencies in Pregnancy, and I'm William E. Franklin, DO. And I'm in Bakersfield, California. You're probably like, well, that guy sure sounds good looking, but nope, not. That's me. Paid for the headshot, got to get some use out of it. First, let's talk about eclampsia. I'm going to just cut to the meat, and then we'll talk about details later. So eclampsia is convulsive seizures in the setting of preeclampsia, pregnancy, proteinuria, and hypertension. And the treatment is labetalol and hydralazine and mag sulfate. The dose of labetalol is 20 milligrams IV, and then you can give 40 to 80 milligrams every 10 minutes to a max of 300 milligrams. Then you can start an infusion at 1 to 2 milligrams per minute and titrate it. You want to get pressure somewhere between 140 to 150 over 90. So that's the goal of your therapy. Hydralazine can also be used 5 to 10 milligrams IV and then 10 milligrams more in 20 minutes if needed. If no response, go to other drugs. We'll talk about those later. I would typically just give 10 milligrams IV hydralazine up front. And then you can give, like I said, another 10 later. Magnesium sulfate is used, it's 4 to 6 grams IV loading dose. And then you can do a 2 grams per hour drip. Now that's if delivery is imminent. Now, if the pregnancy is greater than 34 weeks gestation, they might decide to just go ahead and deliver the baby. But if it's not 34 weeks yet, they might not be ready to go. There's issues with lung maturity of the baby and things of that nature. So mag sulfate is seizure prophylaxis in preeclampsia, and then you're using it in addition to antihypertensives in patients with eclampsia. They're already having seizures, or they're comatose or encephalopathic, but once they have eclampsia, you're going to give them the mag sulfate and you're going to bring their blood pressure down. The three big causes of maternal mortality: hemorrhage, hypertension, and infection. So it's one of the big three that we're talking about today. The normal physiology is that the blood pressure drops during pregnancy across the board. Diastolic, systolic, and the mean arterial pressure all drop. And that starts at about 6 to 8 weeks gestation and reaches its lowest point at about the middle of the second trimester. And it's going to be down about 5 to 10 millimeters of mercury below the pre-pregnancy levels. It'll return to pre-pregnancy levels by the end of the third trimester. Sometimes the diastolic blood pressure drops greater than the systolic blood pressure, and you'll see a widened pulse pressure, but that can be normal. It's a spectrum of disease. Chronic hypertension in pregnancy, not as severe as gestational hypertension. Then preeclampsia without severe features, then preeclampsia with severe features, then eclampsia, and then HELLP syndrome. Chronic hypertension in pregnancy is defined as blood pressure greater than 130 over 80 on 2 occasions before 20 weeks gestation or persistent beyond 12 weeks postpartum. Before 20 weeks gestation. Just remember, the 20-week mark is a very important mark in these disorders. It's not benign. It does increase the risk of abruption, premature birth, preeclampsia, fetal demise, low birth weight, and C-section delivery. The maternal and fetal risks of chronic hypertension in pregnancy occur in the second half of pregnancy, and they typically are preeclampsia, eclampsia, HELLP syndrome. So again, chronic hypertension in pregnancy is not benign. 20% of chronic hypertensive patients go on to develop preeclampsia. It contributes to maternal mortality with CHF and stroke. The treatment goal is a blood pressure less than 130 over 80. And if the diastolic is greater than 110, that is associated with placental abruption and intrauterine growth retardation. A systolic blood pressure greater than 160 is associated with intracranial hemorrhage. Labetalol is the first-line agent for control. ACE inhibitors and angiotensin receptor blockers are contraindicated. Hydralazine and hydrochlorothiazide can be added as adjuncts to your labetalol. Gestational hypertension. It's the most frequent cause of hypertension during pregnancy. It's defined as uncomplicated hypertension with a blood pressure 140/90 or more after 20 weeks gestation or in the immediate postpartum period in the absence of proteinuria. And it's more common in the nulliparous females. Risk factors include prima gravidas, those with a family history of hypertension, age less than 20 or greater than 40, obesity, and multiple gestations, such as twins, as you see in the picture. They're little, but they're sucking the life out of their mother already. Treatment is the same as chronic hypertension in pregnancy. It's labetalol, nifedipine, methyl-dopa. You can use hydralazine in the hypertensive emergency situation. The maternal fetal complications are similar to the chronic hypertension. Consider trophoblastic disease if you see it in early pregnancy, such as in the first or early second trimesters. Preeclampsia, also known as gestational hypertension with proteinuria. It's defined as hypertension with proteinuria that develops after 20 weeks of pregnancy or within 4 weeks postpartum. And this can be a new onset or sudden increase in their baseline proteinuria. Preeclampsia accounts for approximately 50% of all hypertensive disorders of pregnancy. Its pathophysiologic mechanism is widespread endothelial damage. And the risk factors for preeclampsia are age less than 18 or greater than 35, a previous history of preeclampsia, diabetes, renal disease, a BMI greater than 30, collagen vascular disease, triploidy, multiple gestations, and the interpregnancy interval of less than 2 years or greater than 10 years. And what's triploidy? Well, it's that picture to the right, 3 chromosomes instead of 2. Two-thirds of all cases of preeclampsia are in the nulliparous. It's the leading cause of maternal and perinatal morbidity, and it's associated with a 20-fold increase in perinatal mortality. It was first described by Hippocrates. Eclampsia is from the Greek word for lightning. There is a spectrum from preeclampsia to convulsive eclampsia, and you're going to see mild to severe proteinuria, mild to severe hypertension, platelet dysfunction, hepatic involvement, pulmonary edema. It may also manifest with multiple organ dysfunction owing to systemic endothelial damage. And that can affect the CNS, hepatic, pulmonary, renal, and hematologic systems. The development of seizures rarely occurs in the setting of a normal blood pressure and the absence of proteinuria. Let's talk about preeclampsia without severe features. That's defined as a blood pressure of 140/90 or more at greater than 20 weeks gestation with more than 0.3 grams of proteinuria over 24 hours without other signs or symptoms. This can be treated as an outpatient with close follow-up and fetal monitoring. Labetalol is the first-line therapy, 200 to 1,200 milligrams PO daily in 2 to 3 divided doses. Alpha-methyl-dopa is also a first-line agent and can be given at 0.5 to 3 grams a day in BID dosing. Preeclampsia with severe features. That's defined as a systolic blood pressure of 160 or more, or a diastolic blood pressure greater than 110 or more, on more than 2 occasions, at least 6 hours apart, plus any of the following findings: visual disturbance, mental status disturbance, pulmonary edema, cyanosis, right upper quadrant abdominal pain, epigastric pain, abnormal LFTs, thrombocytopenia, and the asterisk over there that says HELP, that's starting to sound like HELP. Oliguria, less than 500 milliliters over 24 hours. And proteinuria in preeclampsia with severe features is 5 grams or more in 24 hours, or 3 plus protein on a dip, and 2 samples at least 4 hours apart. So think about that. You don't have time to do a 24-hour urine collection in the emergency room in this situation, but 3 plus protein on 2 samples 4 hours apart is enough to get you that. And if you're going to do the blood pressure 6 hours apart, that's going to get you that diagnosis. Now, you might have to start treating before you get to that, and just know that. Eclampsia, now that's when you have seizures or coma or encephalopathy in the setting of preeclampsia. You're going to treat the blood pressure within 30 to 60 minutes because that decreases the risk of maternal stroke. Now, we know we say time is muscle in cardiac care, and we say time is brain in stroke care. Well, time is endothelial damage in eclampsia care. Then you're going to give mag sulfate 4 to 6 grams IV plus the antihypertensives with a goal to get that blood pressure to 140 to 150 over 90. Now, when you give mag sulfate and you ask for 4 grams over 20 minutes, you might get pushback because the hospital might have protocols that say, no, you got to give 4 grams over 2 hours. Just let them know that this is a different condition that requires 4 grams in very quickly. In 20 minutes, that's your goal. Systolic blood pressure is the most important predictor of maternal cerebral injury. And like I said before, goal of therapy, 140 to 150 over 90. Step 1, treat the blood pressure. Labetalol IV, but you can also give it PO if you don't have IV access. And you can also use oral nifedipine or IV hydralazine. And alternatives, if the above is not effective, nicardipine, esmolol, nitroprusside, and you want to be in consultation with the OB for that. Step 2 is your mag sulfate, 4 to 6 grams IV over 20 minutes, and that's for seizures or seizure prophylaxis. Then you start them on 2 grams an hour over 24 hours. Benzodiazepines are also indicated for seizures in the usual seizure dose. So don't think that you can't give benzos in eclamptic seizures just because you're supposed to give mag sulfate. You can and should, if it's necessary, give them that. Consider corticosteroids if preterm delivery is imminent and you want to consult with OB. Maintaining normotensive state is not shown to prevent preeclampsia. However, low-dose aspirin is. So you might see people on low-dose aspirin and they're pregnant, and you're kind of like, hey, what? You're not supposed to be on aspirin when you're pregnant. Well, for prevention of eclampsia, yeah. Now, you evaluate the patellar reflexes and the respiratory rate to detect magnesium toxicity. So when you have them on this magnesium drip and bolus, you want to be checking the reflexes and their respiratory rate. Just keep an eye on that. HELLP syndrome. It's along the continuum with preeclampsia. It's rare but life-threatening. It requires the presence of hemolysis on the peripheral smear. Platelet count below 100,000. Consider other causes when you see hemolysis, such as acute fatty liver of pregnancy, hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. There's going to be lab abnormalities, schistocytes on the peripheral smear, and that's the picture there. You see these little abnormal shaped red cells. Platelets less than 100,000 or less than 150,000, but with high suspicion. Elevated ALT, AST, but it's still going to generally be below 500. You're going to have normal to elevated BUN and creatinine. You're going to have an abnormal PT-PTT. You're going to see an LDH greater than 600. That's a sign of hemolysis. And a bilirubin greater than 1.2. HELLP is a clinical variant of preeclampsia. It's more common in the multigravida, and they might not be hypertensive. And guess what? They're going to present with right upper quadrant or epigastric pain, and they're going to have these lab abnormalities, and you might get drawn down towards a gallbladder disease or obstruction. Especially if they're postpartum, you might not even be thinking about HELLP syndrome. Per Tintinelli's 9th edition, a pregnant woman greater than 20 weeks gestation up to 7 days postpartum with abdominal pain should be evaluated for HELLP syndrome. And there's complication from all these: DIC, coagulopathy, spontaneous splenic and hepatic hemorrhages, end organ failure, maternal death, fetal death, abruptio placenta, and intracranial hemorrhage. The disposition, as we said before, mild preeclampsia can be discharged. You're going to admit your severe preeclampsia, eclampsia, and HELLP syndromes, and you're going to admit them or transfer them to a high-risk OB unit. Treatment is delivery, especially if the patient's greater than 34 weeks gestation. You can replace the coagulation factors and the platelets as indicated. So in summary, we're talking about seriously ill women who are pregnant, greater than 20 weeks. There's multiple organ systems involved. You're going to treat the hypertension with labetalol, that's your first line. You're going to give mag sulfate over 20 to 30 minutes, even though the nurse is going to go, that has to go in over 2 to 3 hours. You're going to remember getting an LDH and some coags. And just remember that all of these things can occur postpartum. Thank you. That is the spectrum of hypertensive disorders in pregnancy.